Good afternoon from me as well. Thank you very much for the invitation. The case I'm going to present actually highlights our close collaboration, what all of us should do with our surgical colleagues, because patients can overcome any technology we have, so we have to find ways to serve them the best way we can. I don't have any conflict of interest. So this is a gentleman, he's 62 years old, initially admitted with substernal chest pain. The only known history of his was a peripheral artery disease. He had bilateral common iliac stents. And he was diagnosed with a non-STEMI. Initial cardiac ultrasound showed an EF of 40-45% with hypokinesis on the anterolateral wall. Aortic stenosis was a new finding as well, with a mean gradient of 52 and a or 0.7. What catches the eye on the initial angiogram, apart from that subdural occlusion in the prox-to-mid LAD, is the porcelain cup sitting on his chest. I don't know if anyone needs more proof that this is a porcelain aorta, and he's a relatively young patient. You can even see the leaflets opening up and down with no motion at all, no contrast, no nothing. The right coronary artery was okay. So at this point, we know that as far as Euroscore goes, is like 5.9%, and his STS is 1.7. But the CT aortogram, apart from the porcelain aorta, showed another surprising fact. You can see the leaflets here. It's as if you already have a valve in place with all the calcium. But the extent of disease and the length of the disease on bilateral iliacs with stents in the wall, you just see a small picture on the bottom right of the screen. Pretty much prohibited access from any groin. We thought about all the calcium modification devices we have from Orbita, from Rota, from Shockwave. But this is not just the calcium, it also has stents in there. And the length of the disease on both groins were so long that we thought that it would be, no sheath would cross over there. So the question for this was, how do we proceed? He's a young gentleman with a prox LAD and STEMI, so his initial presentation is acute coronary syndrome. He has severe aortic stenosis, he has severe bilateral iliac stenosis. Do we still think surgery is an option? Surgical aortic valve and PCI, all combinations, TAVI and PCI, off-pump lima, surgery with TAVI. Since we had to, any consideration we could do for giving him a transcatheter valve, we would have to find a way to access. So subclavians had disease too, carotids had disease too. So what we ended up deciding was we would do a hybrid procedure, open up the chest, give him a lima to his LAD, which is something that not many people would say no for a 60-year-old with a prox LAD lesion, and then find a spot to do a direct aortic stick. Going through his CT angiogram, we found a spot about 6.5 centimeters above the aortic annulus. That could potentially be a target for that. So we set up our hybrid room, and once you start, there's no stop. We cracked the chest open, and our surgeon put an off-pump lima to his LAD. We found a spot right at 6.7 centimeters above the annulus that our surgeon put a suture in, trying to insert the 14 French sheath from a hole in the aorta. We had to fight another obstacle. The tip of the sheath is long, so we had to cut the tip of the sheath because that would damage our valve and the LVOT. And then we put a Kelly clamp very close, so where you see it on the right picture being placed is exactly the spot where we had to mark it fluoroscopically, because we would have to pull the sheath all the way back for our valve to have enough room to expand. So you can see pretty much the tip of the sheath, and it's not back all the way yet, but the valve has no adequate room to expand. We're able to cross, pull the sheath back as much as we can. You can see the valve opening up slowly over there. And then we even pulled the sheath back a little bit for the final release. Here you see the final release, and we did post-dilation. There was a little bit of AI. So post-dil, hopefully it's gonna play. So, and here on the right, you see the final result of this case. You see the tip of the sheath is right on top of the valve expanding. Thank you very much for your attention.
Very, very nice case. Very, very nice double solution. I'm a little prejudiced because the initial cases published bear my name, so I like the transaortic, despite the fact that it needs a tremendous amount of competence from the interventional cardiology, from the surgeons, and collaboration that it's not so easily to be found. Can I have a comment from the...
Yeah, great case, thank you. What did the patient have for saline aorta? Do you know? What was the...
It seems he's a severe vasculopath, because already at age 40 he had distal aortic disease.
Any radiotherapy in the past?
No radiotherapy.
No past medical history from...
No, but all his vessels, you
lymphoma? No.
You saw the aorta had disease, the aortic valve had disease, bilateral iliacs had disease, carotids have disease. Probably it's genetic.
Okay, great.
Okay, thank you. We're about 7 minutes late, and we close up the session here with our thanks